Hi, everybody. It's Sue, and I think this is probably getting to the end of where we're talking about these vasoactive drugs. And it's so important to understand them, but I don't want you to memorize them because you're not going to remember them now. You'll use them if you move into high acuity practice settings, but there's no point in memorizing it. I do want you to have a good understanding of what they are and how we're using them. We've already talked about some of those principles of titration and how you look for the peak of the drug and the half-life of the drug. You follow titration guidelines, and there's a little bit of finesse and creativity with that as well, watching your patient very carefully. But let's talk about this just a little bit more, okay? So what we're going to talk about here is the principles of titration, and also we're going to get into drug calculations. And I know you all know drug calculations, but these drug calculations tend to be at a more specific level. So let's go through that for a minute. Okay, and this should be a reminder from the long drug titration PowerPoint presentation. So first, all orders that you see for those titratable drugs, they need to specify a starting dose and a maximum dose. And usually you'll have an order, a preset order for something like dopamine, dobutamine, nitroglycerin, something like that. But they need to have that starting dose and a maximum dose. All orders must specify a hemodynamic and clinical endpoint. So what are we looking for? What is the goal? What is the range that is ideal? Dose titration is based on an individual's clinical status, right? So how they are presenting, what is the clinical picture, and also how they are responding to that medication. So no two patients require the exact same pattern of titration. All of that is reflected in how we see a patient, how a patient presents initially and why they need that vasoactive drug, and then how they respond to the dosing. It's so important that we use the appropriate units, right? So is it micrograms per kilogram per minute? Is it milligrams per minute? Is it, that we really need to be very precise with our appropriate units. It's so important that the concentration of the infusion and the dose are verified again against the orders and the pump settings. This is where it all gets specific. And we said the more you are able to enter everything into your pump, the more your pump is going to provide you with a safety mechanism with lockouts that you can't do something that's unsafe, although you still can titrate in an unsafe manner. So be cautious about that. But it really is essential that you're verifying this, because tiny bits of this, tiny amounts of these drugs can have a very significant impact. And again, do you remember Leslie talked about it when we did one of our Sunday conversations, that vasoactive drugs are looking at alpha-1, beta-1, and beta-2 receptors. And I'm going to talk about that in a second. I think it's the next slide. So let's go over that one more time. So the main targets when we're using all of these vasoactive drugs, dopamine, dobutamine, nitroglycerin, neosynephrine, that we're looking at alpha-1, beta-1, and beta-2 dopamine receptors. So let's see the impact that we're expecting to have. So when we look at those alpha-1, they're located in the walls of our vasculature, right? And when we use them, that causes vasoconstriction. So imagine if you have a low blood pressure that's related to those vessels losing tone, then if we give that alpha-1 adrenergic medication, that is going to stimulate that vasoconstriction of our those blood vessels. They also have receptors in our heart, and within our heart, when we give those medications, they can increase the duration of the contraction, so a longer contraction without decreasing the heart rate. And that's really important. So we're not lowering the heart rate, but we've got a longer contraction. Longer contraction means we have greater outflow, and we have more blood that is being pumped out with each contraction. So we have that better filling time, and then that contraction. So the beta-1 receptors, so that was that alpha-1. Beta-1 receptors are found in the heart, and they cause an increase in the force of contraction. Now, do you remember alpha-1 increased the duration of contraction, and it also increased vasoconstriction. Beta-1 increases the force of contraction, and the rate of contraction, increasing force of contraction, increasing rate of contraction, but minimal vasoconstriction. So do you see how already these drugs are not equal, are they? And so we also have some beta 2 receptors that are found in our blood vessels and our lungs. So beta 1 is in our heart, that causes increase in the force of the contraction of our heart and the rate of contraction. Beta 2 receptors are found in our blood vessels in our lungs, and those cause vasodilation and bronchodilation. So alpha 1 vasoconstriction, increase in the duration of the contraction. Beta 1 located in our heart, and they increase the force of contraction and the rate of contraction. Beta 2 receptors, when we stimulate those, those are in the blood vessels in the lungs, and they cause vasodilation and bronchodilation. So do you see how beta 2 is opposite to alpha 1? And then finally, we have the dopamine receptors, and those are found in our kidneys, our renal system, our mesenteric, and our cerebral, so vascular beds, and they cause vasodilation. So there's also a subtype of dopamine receptors that causes vasoconstriction, and that induces norepinephrine release. So you really need to understand those dopamine receptors. Okay, and here's an example of all kinds of drugs. So you see how we're not just operating from nowhere. There you would have all kinds of tables of vasoactive drugs and how you would titrate them, the beginning rate, the typical low end and upper end of those titrations. And so this is just an example where we see dobutamine, dopamine, epinephrine. We've got some labetalol. And so what your job would be is to know if I said this is an alpha 1 inhibitor, or if it's an alpha or it's a beta 2 agonist. Your job would be to understand where are those alpha or beta receptors, and how, when we impact those in a positive way, so we increase it or decrease it, what is the impact on patient condition? What is the impact on the heart? What's the impact on the lungs? What's the impact on the blood vessels? And you'll notice that we have a basic titration rate. So for example, if we look at dobutamine, it says titrate every 15 minutes, and it gives us some parameters. Dopamine says titrate every 5 to 15 minutes. And labetalol says titrate hourly. So that gives us a basic range. Of course, your hospital is going to have, your healthcare setting is going to have specific orders. Also, they give us the parameters. So cardizem up there is going to titrate to heart rate and BP. Let's see, dopamine is going to titrate to mean arterial pressure greater than 60 or whatever is ordered. Labetalol titrate to heart rate and blood pressure, whatever is ordered. These are general guidelines. I'm not asking you to memorize a thing, right? Because that's not going to be helpful, but you can look things up, right? So don't forget, you have that power to look things up. Okay. So it's really important to recognize that vasoactive medications, these medications that we're giving are indicated when the systolic blood pressure drops more than 30 millimeters of mercury from your baseline, right? So your systolic blood pressure drops more than 30 millimeters from your usual, or from what has been previously recorded for you, or a mean arterial pressure. And you remember I talked about that in another recording, that you can do like a calculation for a mean arterial pressure, which is not accurate, or we put in hemodynamic monitoring, and we actually measure that mean arterial pressure. So a mean arterial pressure less than 60 millimeters of mercury, and sometimes they say 65, so just to keep an eye on that. Or when there's evidence of end organ dysfunction. So for example, you may have no urinary output, or you may have an elevation in liver enzymes, something like that, that tells you there's an indication for end organ dysfunction. And also critical that before we start these vasoactive drugs, somebody's got a low blood pressure, before we say, okay, let's get that dopamine going and bring up their blood pressure, we need to do that fluid replacement, right? So hypovolemia always has to be completed prior to it beginning these vasopressors, right? Because if the problem is hypovolemia, the solution is managing fluid volume status. right? And so we're going to end up chasing our tails in a very devastating way. So correct any fluid volume deficit before you move to the use of vasopressors. We've already talked about all of this. The pump needs to be labeled. The site needs to be labeled. Bag is labeled, all of that. All meds are compatible. We always have that bolus or mini line bag available, and it's well labeled. So we've always got a line that I can immediately use. It's important to understand which drug to titrate first. So if we've got multiple drugs that are working collaboratively I guess collaboration is not a good word, but together, we've got multiple drugs that are working together. We need to know which one is the one we titrate before we move to the next. If they're, let's say I've got 2 drugs for blood pressure support, which one is the one I'm going to titrate first? And important to recognize that we have, if we have multi-infusion pumps, they're all secured on a pole, right? So we've got, we typically have those triple pumps where we have 3 different lines per pump, and we make sure that that's secured on a pole. Let's talk about calculations just for a minute. This one is easy as pie, right? When we're looking at something to look at finding the concentration in milligrams per mil, we look at the amount of drug in the bag in milligrams, and we look at the total volume in the bag. And in this case, it actually would be a bottle. So we've got nitroglycerin, 25 milligrams, and it's in 250 mils of D5, right? So, excuse me, 25 milligrams over 250 mils equals 0.1 milligram, or we tend to now talk, because it will get confusing if it's too much into the points, we talk 100 micrograms. So 100 micrograms per mil. And let's go on to another one. When we're looking at dose per minute. So we've got, again, concentration in the bag. And so that's milligrams per mil. We just did that on the last slide, times the infusion rate over 60. And that's going to give you your dose per minute. So let's say here we've got procainamide, and we know that it's 4 milligrams per mil. We've calculated that it's 4 milligrams per mil using that calculation just on the previous slide. It's infusing at 30 mils per hour. So someone tells me that, okay, procainamide or pronesol is infusing at 30 mils per hour, but I need to know the dose. It is so critical that I don't know, I need to confirm that the mils per hour is correct, but I need to know the dose. So what I would look at is procainamide, 4 milligrams per mil, times the infusion rate, 30 mils, over 60 minutes, because we want it in minutes. This is giving us the dose per minute, and that gives me 2 milligrams per minute. So I'm going to remind you, I come in to get report and somebody says, okay, you've got your procainamide running at 30 mils an hour. I want to know, I must know, what is the dose that is infusing. So I'm going to start with my, I've already figured out what the concentration is in the bag is in milligrams per mil, right? And we've come up with 4 milligrams per mil. I'm going to times that by the infusion rate, and they told me it's 30 mils per hour. And I'm going to divide that by 60 minutes per hour. And that gives me 2 milligrams per minute. I'm going to give you some practice questions, but it's so important that I am confirming this. And as I'm titrating, I need to know both the dose that I'm infusing and the rate that that is equivalent to. Okay, this is an interesting one, and we're going to do mics per kilogram per minute, and we're going to do 2 different things. So we want in mics per kilogram per minute, which is very common in vasoactive drugs. We're looking at our body weight in kilograms times the dose, and that's going to be mics per kilogram per minute, divided by the drug concentration in micrograms per mil, and that's going to give us the infusion rate in mils per minute. We times that by 60 minutes per hour, and we get the mils per hour. Oh my gosh, head exploding already, right? Or you're all smarter than me, so you're not. So let's say I want dobutamine, 5 micrograms per kilogram per minute for a 60 kilogram patient. So let's look at body weight, 60 kilograms, times the dose, 5 micrograms per kilogram per minute, divided by the drug concentration. Do you remember that's the very first calculation we did in this presentation, which was it. So we would determine what the how many micrograms per mil in the bag, and for dobutamine it's 2,000 micrograms per mil. And so we're going to say, then we get, so that equals 0.15 mils per minute, and we times it by 60 minutes per hour equals 9 mils per hour. Sorry, the notation is wrong. It's 0.15 mils per minute times 60 minutes per hour equals 9 mils per hour. Do you want me to go over that one more time? So we've got a 60 kilogram patient. We know we're starting 5 micrograms per kilogram per minute. So 60 times 5, and we've got all our factors there, all our drug dilution. And we're going to divide that by the drug concentration, which we have already calculated or maybe provided to you. And so for the dobutamine, it's 2,000 micrograms per mil in the bag as mixed. That's going to give us 0.15 mils per minute. And I'm sorry, the mils per minute is the minute is this thing there. So 0.15 mils per minute. But I want to know what the hourly infusion rate is. So I times that by 60 minutes, and I'm sorry that there's an error there, 60 minutes per hour, and that gives me 9 mils per hour, right? So for a 60 kilogram patient, I have, and I'm running 5 micrograms per kilogram per minute of dobutamine. The rate per minute is 0.15 mils per minute, and the hourly rate is 9 mils per hour. There's also something called a calculation factor. And if we calculate the calculation factor, it's sort of a way of going backwards to figure out what is the dosing if I know the rate. So for example, if I have a dose in micrograms per kilogram per minute divided by the infusion rate, I get my calculation factor. Remember the last time we just figured this out. Dobutamine, 5 micrograms per kilogram per minute in a 60 kilogram patient was 9 mils per hour. We just did that calculation. So if we say 5 micrograms per kilogram per minute is 9 mils per hour, so we divide that by the 9 mils per hour, we get a calculation factor of 0.556. So the 5 micrograms per kilogram per minute, and it's running at 9 mils per hour. So we divide it by the 9 mils per hour. Our calculation factor is 0.556. So let's say instead I have, I walk in and the IV is set at 18 mils per hour or 15 mils per hour or something else. What I can do is multiply whatever the milliliters per hour is, and I can come up with what is the dose. So here we go. I'm going to turn my calculator on. Let's say we say it's something hard, 15. Okay, it wouldn't be, but let's say. So we've got 15 mils per hour times my calculation factor, 0.556. And that tells me that it's actually 8.34 micrograms per kilogram per minute. So that's where I can look at the mils per hour that are running on my pump. I can use that calculation factor that I've determined, and that tells me about the new dose. I am not going to ask you about this. This is just letting you know these are different ways of calculating it. Don't worry about this, just to help you understand that there are many approaches, and you will be following these. Here's a couple of examples. Patients on dopamine, 5 mics per kilogram per minute, weighs 60 kilograms. The concentration of dopamine is 400 milligrams in 250 mils, sorry, typo, of D5W. So we've got 60 kilograms times, which is the weight, times the dose, 5 micrograms per kilogram per minute, divided by 1,600 micrograms per mil in the bag, equals 300 times 60 equal, so, and we end up with 11.25 mils. Let's try another one. Oh, we don't have another one here, but I've got a whole, I think I've got 4 examples or 6 examples I'm sending out to you. What you often will see is a titration chart. Doing all of those drug calculations takes a little bit of time, doesn't it? So here is a titration chart when we're looking at a 75 to 80 kilogram patient, 85 to 90, 95 to 100. You get it. You can just look it up. That's it. So don't sweat this. I just really want to understand, have you understand how precise we need to be with our dosing, with our calculations. We need to be comfortable and we need to be confident. And as we're moving to high acuity, the drugs are even more potent. And there is a much higher level of finesse in those calculations. Pumps will help you a lot. You're going to use your calculator all the time for precision, but you need to understand how those calculations are made, because you can enter anything into your calculator and end up with something wrong. Most importantly, use a chart, a titration chart if it's available. Use the pump calculation to confirm. Use the assistance of another nurse if you're working with another nurse. And remember, Leslie shared this with us. Don't just stand there and explain to her and have her say, Actually give it to her, move yourself back and let her, if she's going to be a second check or he's going to be a second check, have that person do it independently so you've actually got it. Okay. Oh, and finally, use your resources, pharmacy, senior nurses, even the physician checking doses. If something doesn't feel right, question it. Okay, I think that's it for this one. Don't sweat this. It's just important to really get a handle on these vasoactive drugs, just the idea of them. I really just want to introduce the idea of them for you because you'll hear them a lot as we move through various classes. Okay, we're done. I hope you have a fantastic day, and I will talk to you soon.